Good morning. I'd like to invite you to this session on retinal imaging, a practical guide for general ophthalmologist. We have technological advancements in the field of retinal imaging happening every year with new equipment coming up in the market, which are very costly and financial strain on the institutions. How much of this does it change on the management of the patient? And what are the instruments or what are the imaging modalities that really make a difference? We'd like try to emphasize on this in this current session. The first talk is by a speaker who needs no introduction. Dr. Saravanan is a senior consultant at Aravind Eye Hospital, Coimbatore, and he'll be talking on the role of invasive angiography in current day practice. Over to Dr. Saravanan. Thank you.
Thanks, Sharath, for this opportunity. So right now, this question arises mainly because we have comfortable non-invasive procedures to evaluate disease progression as well as response to treatment, mainly the OCT and the OCT angiography. So otherwise, this question will not be asked whether we still need a invasive angiography. So we just go about since first when Novotny and Alves, they first did the human angiogram on themselves. Actually, Novotny performed the procedure on Alves, and this is the first angiogram capture in a human eye. So since then, we've been the technique was popularized by Maumni from Baltimore as well as Dr. Donald Gass. They had popularized it extensively and studying it the fluorescent angiogram patterns in various diseases. Recently, what happened is that when they did introduction of both optical coherence tomography and the OCT angiography, so because it is non-invasive and very easily capturable images, now the question arises whether we still need this in today's time when we are mostly avoiding all this. The reason why we don't prefer the angiography is that all the side effects of the fluorescent dye, right from mild itching to severe cardiac arrest and anaphylaxis. So that's the reason why this question is being asked. Otherwise, and also the colored urine of post-operative, everybody is afraid of all this. And this cannot be performed in a few patients, like absolute contraindication being the known allergy and relative contraindication being renal failure, cardiac patients, pregnancy, and people with asthma. So one thing which is absolutely missing in the optical coherence tomography angiography patterns is the leakage. That will only show the blood vessel and it will not show the leakage. It's a very integral component of various diseases, like you see in a CNVM or a diabetic macular edema. So we need to know that the dye is leaking from these places. Whereas the routine OCT will not pick up all these leakage patterns. So it gives a significant edge of fluorescent angiography in over the new OCT angiography. Just showing the difference of how NVD will look like in a OCT angiography which you see on the left and the fluorescent angiogram which you see on the right. So only it will just be showing the vessel, whether it is a new vessel or it's a IRMA. Sometimes you have a confusion because in the disc we can easily identify it's a NVD, but if it's in the periphery, you'll always be confused whether it's an NVE or a IRMA. Whereas in a fluorescein, you will see that immediately you can easily identify that the leakage is very visible. So one more disadvantage is that the current OCT machines only capture a small field of view and they have to take multiple scans to sort of integrate it into a mosaic pattern to give a larger field. Still, this is inadequate compared to the newer fundus fluorescent angiograph. Like this is a picture from the Optos. With one image you can capture from almost 200 degrees from close to aura you can capture, and the whole disease process is easily available in one single click, whereas there you have to take multiple pictures to gain this sort of large. Even then, you can never parallel this Optos and the newer generation wide field cameras. And plus, in poor patients who are not very cooperative, it's very difficult to capture the OCTA. Significant media opacity is again very difficult to capture OCTA, whereas fluorescent angiogram can be decently captured. And one more thing is that some of the classification new diseases like the polypoidal choroidal vasculopathy, the OCT does not pick up some of the lesions very clearly. So here you can see that the presence of the small white dots, that's the polyps, and the underneath branching vascular pattern, which is easily visible here. But a lot of times OCTA will miss out on the polyps. It will only pick up the BVN, the branching vascular network, and it will not pick out. Currently, you can see that this is a comparison of a OCT of a polypoidal choroidal vasculopathy. You can see that the BVN is picked up, but the polyp is missed out on. Polyp is only picked up on the indocyanine green angiography. Plus, there are a lot of companies which have their own algorithms and their own depiction of reports, and that sometimes becomes confusing, and it becomes difficult to translate between different machines. The pictures between captured in different machines is usually not very easily captured. And if the segmentation is not proper, the automatic segmentation is not proper, you can get multiple mistakes actually happening. Here you can see that this is the original image captured by the segmentation done by the machine. The CNM is totally absent, but then we have, because we knew that the CNM is there, we have to actually manually resegment it to give the picture to depict the CNM. So if you are going by only the report, you can always easily miss optical coherence tomography picture. And also you have multiple artifacts, fluid showing an artifact here. And the so again, when you have like an OCTA will not show leakage, and when you have a new network and a mature quiescent network or a new active network, then it becomes confusing, because both will get picked up on OCTA, and you'll get confused whether to treat this patient or not, whereas the leakage will give you the idea of activity for doing a fundus fluorescence angiography. And any media opacity, you tend to get a lot of artifacts, the presence of motion artifacts, the patient is moving the eye, again blink artifacts. So all these things can cause multiple issues, and the aneurysms, because of low flow pattern, they do not get picked up on OCTA. So you have to fall back on the fundus fluorescence angiogram. They're showing the example of the projection artifact. You can see that on the choroidal cut, you can still see the retinal network, that it becomes confusing whether it's a CNVM or a normal retinal blood vessel. So it's confusing. So all these projection artifacts can create a lot of confusion for a beginner. And when there is a significant retinal edema, like a branch retinal artery occlusion here, again nothing is seen. It's totally obscuring the this thing. And again, I'm showing example of some cases where you will absolutely need a fluorescent angiogram or andesite green angiogram. So polypoidal choroidal vasculitis, I told you, because the branching vascular network and the polyps are easily picked up on ICG, and it's gold standard. And for diagnosing RAP lesion, type 3 CNVM, you can see the right angle. You can see the right angle blood vessel dipping into the choroid and filling up the underneath network. Again, FFA and ICG are the gold standard to pick up RAP lesion, and it is easily missed out on a routine OCTA angiography. And again, central serous retinopathy, we want planning treatment, you need to know the leakage, which is totally absent in OCTA. So we have to fall back on FFA to all these patterns. You have the inkblot, smokestack, and the diffuse RP epilepsy in chronic CSR. All these will be missed out on a routine, unless you are doing a routine FFA ICG. And all these inflammatory disorders like serpiginous choroiditis, VKH disease, as well as tumors like hemangioma, melanoma. So in all these cases, you have to fall back, and in the routine invasive angiography of ICG and FFA plays an integral role. Currently, OCT is like a Nazari on the left, until it becomes beautiful as the picture on the right. Still be the big role for invasive FFA as well as ICG. I'll stop here. Thanks for your attention.
Thank you, sir. An excellent talk as usual. So the debate still lies in favor of invasive angiography as of now. OCT has a long way to catch up. So next I invite Dr. Sharath Ravi. He'll be talking about OCT biomarkers in retinal diseases. He did his veterinary fellowship from Shankar Netralaya, Chennai, and he is currently working in Srikant Hospital, Calicut, and KIMS Hospital, Trivandrum. Over to you, sir.
Thank you. My talk is on OCT biomarkers in retinal diseases. We look at the retinal OCT helping to identify specific retinal biomarkers that are important in visual acuity at baseline, as well as indicate the prognosis to treatment. It's a non-invasive, non-contact imaging modality based on the Michelson's principle of low coherence interferometry, and has got an axial resolution of 5 to 7 microns and a transverse resolution of 10 microns. The infrared light from the diode source is split by the beam splitter. It's into a reference beam and a measurement beam. The measurement beam is the one that goes into the patient's eye, reflected back, and reaches the beam splitter to combine with the reference beam, and by a phenomenon called interference. And the time delay, the echo time delay between the two beams is extrapolated into the OCT scan. A normal OCT helps in visualizing all the layers of the retina, while the internal limiting membrane, the RNFL and the RP appear high reflective. The plexiform layers and the external limiting membrane appear moderately reflective, and nuclear layers are low reflective. So the different OCT patterns of diabetic macular edema. the spongy edema being the most common, and there's a diffuse thickening of the retina with hyporeflectivity at the level of the outer nuclear and the outer plexiform layer, and usually this indicates a good response to treatment. Whereas in a cystoid macular edema, you have a fluid accumulation within well-defined cyst or spaces in the outer plexiform layer. Based on size of the cyst, it could be small, medium, large, or it could be giant cyst. Usually these larger cysts are associated with macular ischemia and have a poor prognosis. And this is a giant cyst with loss of ellipsoid zone, and usually has a poor baseline visual acuity as well as a poor response to treatment. Serous retinal detachment, on the other hand, has a good response to treatment, and it correlates with the disruption of the external limiting membrane. There is a subset of patients who have a vitreomacular traction or a taut posterior hyaloid, and these patients usually require surgical intervention in addition to pharmacotherapy. The other prognostic factors include the hyperreflective foci, which are small punctiform lesions, 20 to 40 microns, the reflectivity being similar to the RPE or higher than that of the RPE, no backshadowing is present. These are OCT biomarkers of retinal inflammation and usually indicate a poor prognosis. Their number decreases with treatment. Drill, on the other hand, is a disorganization of retinal inner layers where you cannot differentiate between the inner retinal layers, and there is a usually associated with a severe form of diabetic retinopathy, and there is loss of ellipsoid zone and external limiting membrane, and usually it has a poor prognosis. Coming on to age-related macular degeneration, drusen appear as undulations of the RPE Brux layer with disruption of adjacent layers, whereas the geographic atrophy appears as a depression of the inner retinal layers as the outer layers are completely lost, and RPE thinning with the loss of ellipsoid zone and increased visibility of the Brux and the choriocapillaries. So OCT helps in identification of the activity of the CNVM, the location, as well as the type of CNVM. A type 1 CNVM is the one that is located below the RPE, that is between the RPE and the Brux, and you have a hyperreflective material along with subretinal fluid, and the FA showing a speckled hyperfluorescence. Whereas in a type 2 CNVM is usually located above the RPE in the subretinal space along with subretinal fluid and intraretinal fluid, and on FA it shows the classic lacy pattern of leak. Type 3 neovascularization or intraretinal neovascularization or RAP lesion usually is identified by the presence of cystoid macular edema or pigment epithelial detachment. There could be also an intraretinal high reflective lesion corresponding to the intraretinal neovascularization. Therefore, serous PEDs are usually seen as a smooth elevation of the RPE over a hyporeflective space, whereas your fibrovascular PED is an irregular elevation of the RPE, and you have a heterogeneous feature behind the detached RPE. In a hemorrhagic PED, you don't see the Brux membrane because of shadowing by the blood, and fluid accumulation in CNVM can occur in different compartments, and each has got a different prognostic significance. Where you have intraretinal cystoid fluid is usually associated with the poor prognosis. The subretinal fluid usually has a better prognosis and lower rates of atrophy. And presence of pigment epithelial detachment is associated with less favorable outcome because there is an increase in the retreatment frequency. Some of the structural OCT biomarkers include the photoreceptor disruption, which is very common in neovascular AMD. There is disruption of foveal external limiting membrane or the ellipsoid zone and indicates a poor baseline visual acuity and poor response to treatment. Whereas hyperreflective foci are also seen in AMD, and these in higher numbers persisting even after treatment indicate non-responder. The other structural OCT biomarker is the outer retinal tubulation. These can be present in the outer nuclear layer, and these are seen as round hyporeflective lesions surrounded by a hyperreflective band and also indicate a poor prognosis. There could be subretinal hyperreflective material, which could be either fluid, fibrin or blood or a neovascular tissue, and the height of the subretinal hyperreflective material along with the foveal location indicates a poor prognosis. RP RIP usually occurs in a pre-existing fibrovascular PED, and it could be either a spontaneous or due to treatment. It usually occurs in those with tall PEDs more than 550 microns or a large basal diameter ones. And usually the foveal involvement of the RP rib is associated with a poor prognosis. And presence of vitreomacular traction or adhesion in neovascular AMD also indicates a poorer response to your pharmacotherapy. They require a higher number of injections, and some of these might need surgical intervention. An epiretinal membrane on OCT is seen as a hyperreflective band over the retina, which could be globally or focally adherent. It indicates the amount of retinal thickness and also differentiate between pseudo holes and true holes. This is an OCT-wise staging of the epiretinal membrane. And in epiretinal membrane may be associated with a lamellar hole, which could be a degenerative lamellar hole with a large cavitation of the outer retinal layers with a foveal bump and loss of ellipsoid zone, both indicating a poor prognosis. Whereas tractional lamellar holes can appear due to schisis-like separation between the outer nuclear and outer plexiform layers. And here the ellipsoid zone is intact. Vitreomacular adhesion and traction are two entities during a spectrum of partial PVD. In vitreomacular adhesion, the partial PVD is not associated with any change in foveal contour, whereas in vitreomacular traction, you have change in foveal contour because of a distortion of foveal surface, intraretinal structural changes, or elevation of fovea from the surface of RPE. Whereas full thickness macular holes are full thickness interruption of retinal layers at the foveal center, either due to an anteroposterior or tangential traction, and these can be graded according to the size of the hole and the presence of VMT. So coming to OCTA, Dr. Saravana has already given a brief preview of the OCTA. It's a non-invasive imaging of the retinal and choroidal vasculature using a motion contrast. Repeated B scans are taken at the same retinal location, and any change in the phase or amplitude of the scan indicates a flow of RBCs within the vasculature. So the machine actually divides this cube scan into multiple segments, and each slab is known to represent a particular anatomical layer. So this is a type 1 CNVM fibrovascular PED with subretinal fluid on normal spectral domain OCT. On OCTA, it shows a tangled web of fine vessels in the avascular complex. And this is a peripapillary CNVM, not seen well on the spectral domain OCT, showing an irregular RP and a trace subretinal fluid. But on OCTA, it shows the in the avascular complex a glomerulus or a medusa-shaped pattern of vessels. A type 3 CNVM is usually seen as a small high-flow vascular tuft in the deep vascular complex, whereas in diabetic retinopathy, it can demonstrate the microaneurysm. However, they are less sensitive in detecting microaneurysm as compared to a FA. It can also demonstrate the areas of capillary dropout and the enlarged foveal avascular zone and demonstrate new vessels rarely. In MACTEL, you have a capillary dilatation and tortuosity, increased intervascular spaces, and decreased vessel density in the deep vascular complex. Can also detect the CNVMs early. In a branch retinal vein occlusion, there could be enlargement of the foveal avascular zone, areas of capillary dropout, collateral vessels, and microaneurysms, as well as detect new vessels. Thank you.
Thank you, sir. An excellent talk. Next, I call upon Dr. Harshali Kamath. She'll be talking about B scans. So, Dr. Harshali is a senior vitreoretinal surgeon working at in Trivandrum. She completed surgical vitreoretinal fellowship from Shankar Netralaya, Chennai.
Good morning, everybody. I'm Dr. Harshali. As Dr. Sharath was asking, are these imaging still relevant? I think ocular ultrasound still plays a very important and a relevant role even in a general ophthalmology clinic. I won't go into the physics because of the paucity of time and will lay more stress on the pattern identification of different conditions and the techniques involved. So it's a go-to imaging in opaque media in cases of mature or advanced cataract, in cases of vitreous hemorrhage, corneal opacity, hyphema, hypopyon, small pupils, retrolenticular or pupillary membrane, and in cases of inflammation. There are other indications in clear media, but they're more in retina clinic. Now, the for using the techniques that we use commonly, you have to lay stress on the probe marker. Based on the probe marker, you can decide on the topography. So you have three types of scans that you do: the transverse, the axial, and the longitudinal. Coming to the transverse scan, the probe marker is placed parallel to the limbus, and it is very important for showing the circumferential or the lateral extent of the lesion. In cases of axial scan, you place the probe marker over the cornea, as in this case, and you can do it either in the horizontal direction or in vertical. In longitudinal scans, the probe marker is placed perpendicular, as you see in this image, and that shows the lesion's anterior-posterior extent of any lesion. Now let's, if you're doing a general screening, then you can do the 4 transverse scans, the 2 axial scans, or one of the longitudinal. Now let's come to the pattern identification. In posterior vitreous detachment, you will get a low to moderate reflective membrane. Most importantly, it will have good after movements. It can be attached either to the disc or any part of the retina, wherein it will be called an incomplete PVD, or if it is completely detached, then it's a complete PVD. Sometimes in vitreous hemorrhage, the posterior hyaloid might appear very high reflective, in which case you may have to differentiate from the retinal detachment based on its after movements. In vitreous hemorrhage, in case of fresh vitreous hemorrhage, you may see a dot or clump-like echos, and you have to remember to do it also in the higher gain. As the vitreous hemorrhage ages, it becomes more organized, and you might start seeing membranes and clumps. You may have PVD associated with it, and sometimes you may have echos behind the hyaloid, which will be the subhyaloid echos. You may have vitreoretinal adhesions, and that can give rise to tractional detachment. Sometimes you may see splitting of the vitreous, which we call as the vitreoskisis, and it's important for the retinal surgeons because then they have to look out for the second membranes during the vitrectomy. There are several mimics which we need to know. One is asteroid hyalosis because it's so common, and you have to differentiate it from the vitreous hemorrhage. These are high reflective discrete echos, and very commonly you will see a clear space between the asteroid and the retina. Sometimes you may see a closed funnel RD and completely miss the central stalk, as in this case, in which case you might mistake it for a vitreous hemorrhage. Endophthalmitis I will discuss in the later slides. As I was saying, the previous closed funnel RD, if you miss the stalk here, then you might assume it to be a vitreous hemorrhage. Coming to retinal detachment, here it will be a high reflective membrane echo, and it will persist in low gain as long as the probe is perpendicular to the surface. It will have poor after movements, and if it becomes long standing, it will lose its mobility and may have a funnel shaped configuration. Sometimes you may have this unusual echographic finding in case of giant retinal tears, where you will see double membrane folded over itself. Exudative RD, you may demonstrate shifting fluid either in sitting position and then supine position, where you can demonstrate the fluid being shifted. You may have associated retinochoroidal thickening. In tractional detachment, you can have various type of configuration. You can have a mild focal detachment, you can have a tabletop configuration at the posterior pole, or a hammock-like configuration. A small dome-like low high reflective membrane in the periphery is suggestive of retinoschisis. Choroidal detachment will be high to moderate reflective dome-shaped echo in the periphery. It will have no after movements or very minimal, and sometimes you may be able to demonstrate this thin line, which is the vortex membrane. On a scan, you may have a M-shaped spike. To differentiate whether it is a hemorrhagic or serous, you may find these suprachoroidal dot echoes in a hemorrhagic. Coming to infections and inflammations, in endophthalmitis, if you see a cobweb-like echo along with these dot and clump, it's more suggestive of inflammation in endophthalmitis. There'll be sub-highlight echoes if there may be associated PVD. If it is progressing to panophthalmitis, you may have localized subtenon's widening or in advanced cases the T sign, wherein you see this subtenon space widening along with the optic nerve shadow of a T sign. In scleritis, again, you may have thickening of the sclera with an associated T sign, which I demonstrated earlier. Cystic is a very typical echolucent cyst with the echodense nodule within it and very characteristic of cystic. Coming to trauma, which is also a common indication for ultrasound B scan, we usually don't do it in an open globe, but in a blunt injury, you can see a subluxated lens, you can see a dislocated IOL, a high reflective echo in the mid-vitreous cavity. You may have vitreous hemorrhage along with scleral dehiscence and vitreous tracking to it, suggesting of vitreous incarceration. Other features may also be present, such as retinal detachment or choroidal detachment. Sometimes you may see a widening of the optic nerve shadow in cases of optic nerve head avulsion. Intraocular foreign body may be seen as a high reflective echo, persisting in low gain and causing shadowing. There are certain tumors which you need to be aware of. Most importantly is the retinoblastoma, where you shouldn't, if you see these calcification, it is very characteristic and shouldn't be missed. Choroidal hemangioma, a circumscribed one, will be seen as a dome-shaped mass with high internal reflectivity. The diffuse one will not have a specific mass, but just a diffuse high reflective thickening. Melanoma may have a collar button shaped appearance, and you may demonstrate you may show choroidal excavation with scleral bowing. Metastasis may have a lumpy, bumpy appearance with exudative RD. Certain pediatric condition in advanced ROP with closed funnel, you may find this high reflective echo. There may be different types of configurations, such as anterior open or a posterior open, which you need to document. Coats disease won't have any particular mass lesions, but you'll be able to show the mobility of these subretinal echoes and forms an important differential for retinoblastoma. But if you see calcification, it's more towards the retinoblastoma. There are certain abnormalities, anatomical abnormalities, which you need to know, such as if you see a smooth excavation, it's a posterior staphyloma, whereas if you see a sharp excavation, as in this case, it's a coloboma. It may be associated with a retinal detachment. The optic nerve head cupping more than 0.7 can sometimes be demonstrated on the B scan. A high reflective echo at the optic nerve head, which persists in low gain, can help you differentiate between a papilledema and a pseudopapilledema in case of optic nerve head drusen. Sometimes in post-vitrectomy surgery and you have a mature cataract and you see certain features like enlarged globe, apparently enlarged globe with the oil meniscus, it's an oil-filled eye. Post-SOR, you may find discrete echoes in the midwit cavity. Thank you.
Thank you, Harshali, for a very exhaustive talk on ultrasound. Next, I call upon Dr. Rahul. Rahul has finished his surgical retina fellowship from Shankar Nethralaya, Chennai, and is currently working as a senior retina consultant at Chaitanya, Cochin. He will talk to you about electrophysiology simplified for a comprehensive ophthalmologist. Over to you.
At the onset, I would like to thank Dr. Sharath for this opportunity. So as a VR surgeon, electrophysiology is something that we all kind of hate. The reason being, we don't, most of this, the big institutes, they have this electrophysiology equipments and we don't come across in a routine practice. So I've been given the tough task of kind of simplifying it for a comprehensive ophthalmologist, I think it would have been apt if we had to simplify it for retinal surgeon as well. So ERG. So ERG is an objective non-invasive measure of the electroretinal function. So it's recorded on the cornea with electrodes. So it gives you a diffuse, so it's basically a diffuse electrical response generated by the neural and non-neural cells within the entire retina on stimulation with light. So it gives us a mass electrical activity from the retina. Now, when we look at an ERG, you have an A wave over here, which is a negative wave, which originates from the photoreceptors. Then you have the B wave over here, which is a positive wave, which arises from the bipolar and Mueller cells, that is from the inner retina. And then you have the oscillatory potentials over here. So these are small, wavelets along the on the ascending limb of this B wave. So these are called as oscillatory potentials, and they arise from the amacrine cells. And then you have the C wave, which is again a positive wave, which comes little later after the B wave, which arises from the RP. Now, when we look at the waves, we are also looking at the quality of the wave. So we are supposed to look at the amplitude, the implicit time, the latency, and also, so what happens is basically the amplitude is from the baseline to the peak of the wave. That is the B wave amplitude. And then you have the A wave from the baseline to the edge of the trough. You have the A amplitude, and that's how you get about the quality of the wave. So an important point is the B is to A ratio. So the B wave is from the inner retina and the A wave is from the outer retina, right? From the photoreceptors. So you give it a good, information about the health status of the inner retina and the outer retina from this ratio. So small amplitude indicates reduced functioning of the cells, and when there's a delay in the time of onset to peak, this indicates that the cells are sick or dysfunctional. Now this is a normal ERG that we see. So we have something called a scotopic response, which is examined in done in a dark adapted state, and you have the photopic response. So simplified, scotopic response gives you an information of the rods, and the photopic responses give you the information about the cone system, right? So you have the single rod response, and you have the combined 30 Hz flicker, everything over here. So this is one thing that we should all know. This is the electronegative wave. So basically when we look at the normal B wave, so we have the A wave first, and then we have a tall B wave usually. Now in certain cases, you will see that after the A wave is normal and the B wave is not that big. So that is the electronegative wave. But at the same time, if the A wave is also affected, that means that the rods are also affected. Okay, so this is a electronegative wave. So this is a normal ERG. You can see that everything others are normal, similar. But in this case, in X-linked retinoschisis, if you see the B wave over here, you can see that's very reduced in size. So these are the various conditions in which you get an electronegative wave. Now, this is an example of a retinal RP, ERG of a RP. So most of the cases, just to simplify it, if you look at a normal ERG, you will see multiple troughs and peak amplitudes. This is what a typical ERG looks like. So you will have flat lines for both rods and cones, and the implicit sign will be delayed. So what is the significance of, is it just for the diagnosis of RP, the ERG? No, it also helps us in prognosis of disease, because what happens is many times when we in a familial screening, we pick up a case of early RP, they want to know whether they're going to lose the vision or whether the visual loss is still progressing. So with what happens is when you get a field test done, or probably an OCT or whatever, you cannot comment about the progression. So this is the one place with ERG we can actually comment about, because if you see the amplitudes reducing, that indicates that the disease is still in a progressive stage. So this is a cone dystrophy. So if you look at the cone dystrophy, what happens is in the rod response. So cone dystrophy, the name itself is self-explanatory. The cones are more affected, the rods are a little healthier. But still, if you see sometimes the A wave, the start of the A wave is delayed, and the B wave will be present, but it will be still little delayed in here. And the cone response is very extinguished. This is a near normal, and you can see that the photopic responses are affected. So this is a cone dystrophy. Now in in a retina, so especially CRA, so we mostly rely on clinical examination or probably an OCT to get that thing, the diagnosis. But sometimes, if you want to diagnose, you can also use an ERG, where what happens is it is one condition where you get unrecordable, ERG, and often in the initial stages, the B wave is the first thing to get affected. Now, these are the conditions where you will find undetectable waveforms. So LCA, ophthalmic artery occlusion, gyrotrophy, the list goes on. Now, multifocal ERG. So it's a high resolution functional map of the retina, so of the central visual field. So you have in multifocal ERG, so this is what you get. You get a trace array and you get a 3D density plot. Now, most of us will just look at the 3D density plot and we'll say that this is the foveal peak, right? So if we say that the peak is kind of blunted, we'll say this is a kind of, some pathologies affecting the fovea. But you are actually supposed to look at this. This is the most important thing. So if you see at the waves over here, there are two negative waves and one positive wave. So you have the first negative wave, then you have one positive wave, and then one second negative wave. So that is called as the N1, P1, N2. So you are supposed to actually comment about on the basis of this trace array. So depending on, say, probably if an HCQ toxicity, I have a picture coming up. So in HCQ toxicity, you will see a particular second line, second grow of this, the trace array will be affected. And that's how you can actually, it's very important in its significances in more of drug toxicity. So, they have a stimulus pattern of usually 61, 103, and 241 hexagons to cover it. Usually around 50 degrees of the visual field is examined. So basically, it's to distinguish retinal disease from optic nerve diseases. It gives a detailed extent of the lesion. It's a sensitive indicator for retinal drug toxicity, and also assess subclinical retinal changes in diabetic retinopathy. So this is the thing I was talking about. So this is a normal multifocal ERG, and this is the plaquenal, that is the HCQ. So what happens, if you can see over here, the peak is okay. You can get a rough idea by looking at the 3D density plot. But if you look at the arrays over here, the second wave, this region is usually classically affected here. So this is very classical of HCQ toxicity. Now VEP, it helps in assessment of the visual pathway. See, basically, the visual cortex is represented, has a major. The macula is mostly. The electric signal generated in the visual cortex is in response to visual stimulation. So VEP reflects the electrical activity of the subject's central field. So the central retina is projected on the surface of the occipital lobe. So what happens is the foveal projection is magnified at the cortex, which is known as the cortical magnification factor. This is M. So we have the flash VEP, pattern VEP, and sweep VEP. So the flash VEP is basically done in patients with media opacity, very low visual acuity, infants, and uncooperative patients. And the pattern VEP basically for optic nerve atrophy, glaucoma, optic neuritis, and so on. So we have three, so just like the other wave, they have the two negative waves and one positive wave. So this is the N75, this is the P100, and N135. So basically it is the timing. So that is 75 microseconds, 100, and this is at 135. So this is like a picture of an asymmetric optic neuritis. So the right eye, this is the normal VEP. So you can see the N1, P1, and N2 here. If you look at this here, the response is a little delayed, and also the amplitude is affected. So this is how an optic neuritis starts. VEP picture of an optic neuritis look like. And flash VEP is done with patients with media opacities and uncooperative patients. Next is EOG. So how do we get an EOG done? So basically what happens is, it is done in both dark and light. So with an ordinary light. The patient comes there, you place the electrodes and you start with normal turn of the light and do it for 15 minutes. You do it to the recording for 15 minutes, and then the next 15 minutes you do it in light. So in the dark, 15 minutes, so usually what happens is we get an amplitude there, a wave there. So the minimum amplitude distance, we usually get around 10 to 12 minutes. So that is the dark rough ratio. And then in the light phase, it's around 6 to 8 minutes, you get the peak. So you take the ratio, and that's how you get the Ardens ratio. So I'll just take one. So this is a normal EOG. So basically what we do is the light peak to dark trough is multiplied into 100 and we get the Arden ratio. The normal Arden ratio is around 1.8. Somewhere between 1.65 to 1.8 is subnormal and less than 1.65 is completely abnormal. Thank you.
Thank you, Dr. Rahul, for your exhaustive talk on electrophysiology. Now I call upon Dr. Karthik. Dr. Karthik is a retina consultant at Arvind Hospital, Chennai. And apart from his Vitretina fellowship, he has done a postdoctoral fellowship in AI and data sciences. And therefore, he would be talking to us on this important topic of smartphone-based retinal imaging and use of AI in retinal imaging. Over to you, Dr. Karthik.
At the outset, I'd like to thank Dr. Sharath for inviting me here. So this is the upcoming field of AI. So right now, whatever you've listened to is what you guys use regularly in the field of clinical ophthalmology. And all the information I'm sharing over here is my personal capacity working with Arvind. I'm not generalizing. I'm just talking about what we do generally at Arvind Eye Hospital with AI. So these are the headings that we are going to talk on: teleophthalmology, diabetic retinopathy, glaucoma, corneal disease surgery, systems biology, and what exists in the future. Why do we have vision centers at Arvind practice? So for people who are unable to come to the base hospital on a day-to-day basis, who are unable to travel, they visit a place which is at a constant distance from their home. At a population around 50,000, we have a localized ophthalmic clinic where it is open 6 days a week. So because of that, we make specialized eye care accessible to all the patients in that population, where we undergo comprehensive eye screening. And we do not have one doctor going to that particular vision center and treating the patient. We have one doctor who's in charge of 10 vision centers. So based on that, we have teleconsultation and prescription that are given. And we bridge this gap of having a doctor virtually present by using technology. And we use our electronic medical record and a teleconsultation network, and also use AI for it. The typical flow is what we have in a regular clinics. Everything is done according to what an ophthalmologist would do, but we have a mid-level ophthalmic personnel who is trained in doing a similar task of what an optometrist would do. So when we bring about smartphone imaging and fundus imaging to this type of a setup, where we need to know what is the utility of a routine fundus photography screening for posterior segment disease. So screening for posterior segment disease can be various. It can be for mass screening, where in a camp you can do it, or a high-risk screening, where only those who are at risk, like a diabetic clinic, or an opportunistic screening, where patients come for any drug toxicity or related medical problems for screening of the retina. So all the fundus photos that are recorded at the vision centers are seen at the base hospital virtually using a Google Meet network. And with this, we have seen about, in 2022, about 900,000 cases, and we have referred cataract surgeries around 67% and specialty care about 50,000. So this is the amount of patients that we could send using teleophthalmology, and we currently do around 3,000 teleconsultations a day using this kind of a setup. And this year 2023 to 25, we are reaching 1 million patients through the vision centers. So this was a setup where we used teleconsultations at the localized centers, which is a virtual center. Then we thought about where else can we do mass screening. In a traditional eye camp, whatever we do, we generally go there, check the patients. We majorly conduct only screening camps for cataract. We do not think about any other implications of the retinal posterior segment disease, no glaucoma, no retinal disease. We just pick up the cataract and come back home. So then we thought about putting in how to screen for glaucoma using tonometers, how to take care of the digital fundus photography. So all patients who are undergoing camps right now go through this novel eye camp where digital tonometry is being done, and all patients, irregular of whether they're going to undergo cataract surgery or they be given prescription glasses, are taken a fundus photo. And once a fundus photo is taken using Wi-Fi, that fundus photo is transferred to the electronic medical record, and where the doctor sees the fundus photo and then decides whether it is going to be a posterior segment disease involving patient or a non-involving patient. So because of this, the referral for the posterior segment disease has increased to threefolds. So this threefold increase of detecting patients who are in requirement of these posterior segment disease has increased the uptake of these patients coming to the base hospital. So the service delivery model, why we have these vision centers and why have these camps, is already known to everyone. Now coming to diabetic retinopathy, if in case you see a diabetic retinopathy patient in the clinic and you have a fellow that you have to teach, you would give them main points like mild NPDR, single microaneurysm, moderate NPDR, more than one microaneurysm, severe NPDR if you watch an IRMA. So same calculation, we put it into a computer and we gave them a ground truth telling that if this image is there, are you going to give an yes or a no for the following questions? So this was early Arvind diabetic retinopathy evaluation screening system where we used a ground truth and we used a doctor to indicate the presence or absence of diabetic retinopathy. Following this, then we met with Google and we had a technological collaboration with Google where we came up with an automatic analysis of using an AI algorithm to detect whether diabetic retinopathy is present or not. So what this algorithm does is it gives you a clinically graded diabetic retinopathy screening, whereby it requires the algorithm to tell you whether it is a referable case of diabetic macular edema or it is going to be a referable case of diabetic retinopathy that needs to be seen by a retina specialist. So this does not omit the retina specialist in treating the case. It just gives you a guidance whether it needs to be referred or not. So this is the report that is generated by the AI algorithm that is at the place of the screening taking place. It can be at the camp, it can be at a diabetic clinic, it can be at anywhere. All you have to do is upload the image and get the report back. So what are the limitations of this? We have to be constantly checking clinically an audit that is being performed to make sure that we have a retina fellow always auditing the images that are being taken by the fundus photographer to check whether the media opacity is clear. And we also report to Google if there are any outcome measures that are not good. And we'll also have to monitor whether the algorithm is doing a good job of detecting moderate NPDR as moderate NPDR and not missing a diagnosis. So once we have set that diabetic retinopathy, we have finally said, okay, and the algorithm is doing a sensitivity and specificity of about 90%. We moved on to glaucoma. What else can we do in glaucoma? So in glaucoma, we came about with an offline on-the-edge AI integrated on a smartphone fundus camera, where it generates a retinal referral report in about 10 seconds. So what you do is you take a smartphone using a fundus camera, you just take a snapshot, and even if you don't have electricity or an internet connectivity, the smartphone has the capability by using an app to detect whether there is a glaucoma that needs to be referred or not. So the healthcare worker or any operator who uses it in a mass screening program or in your clinic where you want to screen as a comprehensive ophthalmologist, you can always use this to detect the presence or absence of glaucoma. So it not only gives you the presence or absence of glaucoma, it also states where the pathology is, and it also indicates the cup disc ratio and the evaluation of any RNFL nerve fiber layer defect. If it is going to be there, it is going to indicate where it is particularly present. So with this, did we prove that it is better than a doctor who is going to see it? Yes, we did prove that it has a specificity of 98%, and it gave a 96.4% of definite glaucoma diagnosis when compared to a 53.5 by a general ophthalmologist. And the false positive referrals in a camp, when you bring in 10 glaucoma patients and say that 10 are not glaucoma patients, you have to reevaluate, then it brings the patient no value gain of bringing him to the base hospital and checking him up. But the AI algorithm gave you a false positive referral of 2 of 10. So it is much better than having an AI tool to guide you in these things. What are the limitations? If you have an algorithm detecting glaucoma in a fundus photograph, it will detect only glaucoma. It will not detect BRVO, it will not detect ARMD, it will not detect other pathologies that are present. And if you require other modalities like OCT to be seen, that is also not there. And you'll have to work with multiple vendors. One might use a Mac OS device like an Apple iPhone, and another would use an Android. So you'll have to limit your modalities to using what algorithm for what kind of vendor to use. And you'll also have to tune your model. Sometimes you might have a patient who, if suppose I'm going to use the same algorithm in Japan or in the Europe areas, the Asian eyes are not equal to their eyes. So then you'll have to change the modality. So, or if a guy from Europe is going to come and get his algorithm to work in India, then it is going to change the modality. And coming to cornea, if suppose in your clinic, if you see this today, if I see this today and I measure the corneal infiltrate as 4x4 or whatever is to be measured, and I want to see this patient again in a week's time, how will I remember what is the size of the corneal infiltrate? How much has it regressed? Is it improved? Is it worsened? I do not know unless and until I have a clinical photograph. Even when I have a clinical photograph, how am I going to know whether exactly the size is measured or not? If you're going to have a clinical trial or a clinical study going on, it is always a difficult task. So then we came about with an automated quantitative ulcer analysis. We call it as AQUA, where it measures and segments the corneal ulcer, it measures the corneal scar, it measures whatever lesion is present in the central of the cornea. If it is going to be normal, it is going to let you know it is normal. And whenever it comes back with the next clinical episode, it always goes back to the previous one and lets you know what is the difference in it. So we have also done for corneal infiltrates from healed scars, whether it is going to be an active infiltrate in a healed scar or it is going to be a healed scar by itself. Or in cases where you have various other disorders like keratoconus, or it is going to be a normal cornea or any ectasias, it is going to pick up. So these are things that we have done in anterior segment of the eye. And we have also based trying to differentiate fungal keratitis from bacterial keratitis without using a gram stain or other stains. Just by looking at the photograph, the algorithm comes up with a plan of saying this is fungal or this is bacterial. And we also use confocal imaging in vivo to make out whether it is going to be what kind of infiltrate. So moving on to surgical expertise with AI, with the collaboration with the Nalasamy lab at the University of Michigan, we are collaborating to know what are the steps that you do regularly in a regular format. If you have a standard operating protocol for SACA saying that you have a 7 millimeter incision in a frown shape to be made, are you making that incision exactly 7 millimeters? Are you going 6 or are you going 8? Is your pupil during your PCR shrinking, or is it widened enough to know that you don't have a PCR? What is your strategy when you do a phaco chop? All these are going to be calculated and measured so that when you train a person, you virtually can understand what kind of training has to be given at which particular step so that he can improvise on that particular step and have a less learning curve. So this is what we are trying to do with the surgical analysis using artificial intelligence. Moving to translational medicine. So in translation medicine, whatever you've done till now, you use clinical lab to do tests on drugs, and you use your rat, your mice and things. We have moved on to use systems biology, where we try to do it on a chip. So these are called as in silico trials of using AI algorithm to know what can be done to treat certain kind of diseases. For example, we use Pseudomonas aeruginosa for cases of endophthalmitis to try to see what we can find out on which drug acts better for Pseudomonas. So the most common drug that we use, Gatilox, Vigamox or Gatilox that we use for Pseudomonas, it did not even make up to the top 20 list. So what we are currently using to treat Pseudomonas did not even come up in the top 20, and the computer algorithm gave us a combination of tobramycin and ceftazidime, which is in the top 3. So these are some things that are coming up now where you do not have to do a 6-year trial to find out which drug is acting better. You can always do it by using an algorithm. So in the future, what holds for us? Everybody knows that we use ChatGPT for each and everything. And for your information, this is not by ChatGPT. This presentation is made by myself. And for people who want to try out new things, there are possibilities of using ChatGPT to find out what is the newer research that is going to happen, or what, depending on your prompt, you will know what to do. And this is the upcoming things. It is better that you embrace this technology rather than saying this is false, this is not good, this is unethical. It is better that you start embracing. So what in the future holds for us? We would require a co-pilot. It is basically like if you're a surgeon operating on a surgical field, you will not do the drape, you will not put the eye speculum, you will just do your phaco and come out. So the same principle. You will not do the refraction, you will not take the clinical report, you will just see the patient, diagnose and give him an advice. So that is what is a co-pilot that is going to come up. And based on this, we have already developed a Center for Ophthalmology and Data Analytics at Arvind, where we are trying to answer whatever algorithms that can be created to make the clinician use his clinical knowledge and does not waste his time. So these are our collaborators that we collaborate for our AI collaborations. And with this, I will end my talk. And if you have any doubts, you can always email me. Thank you.
Thank you, Dr. Karthik. That was a great talk on AI in retinal imaging and the future of ophthalmology. Very exhaustive talk.